So in previous years during CAGLA, they matched us up with a session chaired by Danny Johnson. That was usually easy to beat. Today I have to compete with Mark Matrana. So thank you for not going to hear Mark Matrana talking. So we have three really excellent talks lined up, and then we'll close it out for the GI session at the last 30 minutes doing some cases. And I'm going to try to stump and confuse our great esteemed panelists. So to start off, we have Dr. David Pointer. Dr. Pointer is a New Orleans native. Fun fact, he was in high school with my wife. I'll have to hear some stories later. He went to Tulane for medical school and residency, and then did his surgical oncology training at Moffitt in Tampa, Florida, and joined Ochsner about a year and a half ago now. And proud to call him an awesome colleague who I enjoy working with, see him all the time, and ask him far too many questions for help. And he'll be talking to us about management of GE junction adenocarcinoma from a surgical perspective. So thanks, David.
All right, good morning. Thanks for having me. Like John said, my name's David Pointer. I'm from New Orleans. I have been at Ochsner about a year and a half, and I'm part of the upper GI oncology and surgical oncology group there. We have a very busy practice, and I'm really happy that I was invited to talk today, just to give a little bit of insight in GE junction cancers and how we approach it from a surgical perspective. I know, I apologize, I am a surgeon, so I tend to keep things a little bit more simple. But if there's anybody else who wants more detail and I can't help, we can ask the panel at the end, or Dr. Mizrahi can correct me. I don't have any conflicts of interest or disclosures to discuss today before the talk. And my objectives today, I'd like to cover just the basics of diagnosis and classification of GE junction adenocarcinoma, some of the basic principles of staging and how that pertains to both surgical and medical treatment algorithms. And then some of the details of the treatment approaches and how we handle these cancers in the modern day of 2024, and some of the data that supports our decision making. And then finally, I'm going to show some pictures and videos of some of the surgical techniques that we use. So I apologize if some of you guys might get a little queasy or not. I just thought they were cool and I wanted to show them off. And then I just get a little bit about some adjuvant considerations, since we have some new data that's been published over the past few years that's really changed guidelines. So some basic just anatomy, just to start off. So the GE junction is literally the junction of two different organs where the esophagus meets the stomach, and the Z-line is really that anatomic location where we see the mucosa change from squamous cell mucosa of the esophagus to columnar mucosa of the stomach. Additionally, just from an anatomic perspective, which is important for us surgeons, the esophagus has only two muscular layers and doesn't have a serosa. So when we talk about operating on the esophagus, it creates some challenges for us in terms of reconstruction that I'll address in the future. And the stomach is much more robust, has 4 layers, 3 muscular layers, and then a serosa. When we talk about classifying these tumors, we use something called the Siewert classification. And this is a categorization of these tumors that is performed usually by our gastroenterology colleagues, where we rely on them to show us where the epicenter of these lesions are located within the esophagus or within the GE junction. And the reason this is important is because based off the more recent NCCN guidelines, based on the location of the epicenter of the tumor, it really categorizes these patients into an esophageal pathway versus a gastric pathway in terms of multimodal therapy and even a surgical approach. So type 1 or Siewert 1 classification is located, this is that blue portion on the slide. It's about 1 to 5 centimeters proximal to the GE junction. That's where the tumor epicenter would be located. Type 2 is literally right at the GE junction. So this is 1 centimeter proximal to 2 centimeters distal. And type 3 is 2 to 5 centimeters distal to the GE junction. So type 1 and 2 cancers, currently we treat as esophageal primaries, and they go down the esophageal algorithm or pathway. And type 3 we tend to treat as gastric adenocarcinomas, and they are treated along the gastric adenocarcinoma pathway. So I just wanted to introduce kind of a standard case, one of the more common like the way this cancer typically presents, just to guide us through how we think about these malignancies. So in this case, 60-year-old male who's obese presents with 3 months of dysphagia and weight loss. He's a current smoker and has about a 10-year history of reflux for which he's taken medications for. Because of the dysphagia and weight loss, his gastroenterologist performs an EGD, which shows a 5-centimeter mass at 35 centimeters from the incisor. So this is important for us because they note the GE junctions at 40, and if the mass is at 35, then that tells me this is a Siewert type 1 tumor. So that's some important information that we glean from these endoscopic reports. The mass was biopsied and demonstrated adenocarcinoma. So once we obtain the diagnosis, which is typically obtained by EGD and biopsy that we showed before, the next steps for us, and really anyone on the treatment care team for these patients, is staging. So what do I need to know as a surgeon? There's a lot of details to staging, which I'll show on the next slides, but what's important to me initially, and most of the people on the care team, is does this patient have metastatic disease? Do they have stage 4 disease? And the reason that is important is because if they do, then primary resection, or resection of the primary lesion, is no longer going to be offered for that patient. Any of you guys that are familiar with esophageal work or esophageal surgery, these are very large operations, they're morbid, and what we know based on historical data is that resecting the primary in a situation where patients have stage 4 disease does not affect their overall survival or outcomes down the line. So we don't want to offer them a morbid operation that's not going to help them in the future. Once we've ruled in or out the presence of metastatic disease, the other things that are really important for us on the surgical side is determining the extent of invasion, so how deep that tumor is invading into the esophagus or at the GE junction, and also is there any regional or local lymph nodes that are involved. These can be obtained with endoscopic ultrasound, which I'll cover in detail on the next slide. And then finally, getting back to that Siewert classification I mentioned earlier, oftentimes with some of this local staging that we do, the local regional staging modalities, we can determine the exact extent of the tumor. Where does the lesion start? Where does it end? And where is the bulk of it? Where is the epicenter? So this kind of helps us put it in that appropriate category for treatment. So a little bit more detail on staging. So as many of you guys know in the audience, the first step is really to rule out distant metastasis or the M portion of staging. We like to do this with a combination of a CT, chest, abdomen, pelvis initially, and then we follow that with a PET CT if an original CT is negative. This is just to make sure that we're very comprehensive in identifying those patients who do have metastatic disease so we don't subject them to unnecessary or futile treatment going down the line. Once patients have demonstrated that they do not have metastatic disease, the next step is staging them from a local regional standpoint, and that is the T and N portions of the staging. For that, we use endoscopic ultrasound, and that's the image you're seeing in the bottom right-hand corner of the slide. We can appreciate the T stage, which is the depth of the tumor invading into the esophagus, as well as the N, any local lymph nodes that we may see on the ultrasound, which you can see in that bottom right-hand picture. It's important to note that EUS is quite accurate, 76 to 90% for T and N stages. The only place where it really is not ideal is for early cancers, so delineating between T1A and T1B. Oftentimes, for those specific lesions, we do move forward with something called an EMR or ESD, where the GI doctors can remove that portion of the tumor and we can look at the depth of invasion under the microscope. So that can either be therapeutic, if it truly is T1A, or diagnostic and provide us more information on staging, and we can appropriately allocate those patients on the correct treatment path. A few other notes about endoscopic ultrasound with staging. Stenotic or obstructing tumors oftentimes are understaged with EUS because the scope itself can't fit past the lesion, so we can't get a good picture of it. We also don't use it when we follow up with restaging. Typically with restaging after neoadjuvant therapy or therapy before surgery, we're really just making sure that there's been no development of new metastatic disease. So the risk of another EUS typically in most patients is not beneficial. Really, the bottom line to all this staging is we're trying to put patients in the appropriate treatment group to determine whether they need neoadjuvant or multimodal therapy or if they can proceed with upfront surgery. So just a few of the treatment algorithm guidelines per the NCCN based off of staging. So I covered this a little bit on the previous slide, but patients with very early disease, so TIS, that's in situ disease, or T1A, we typically recommend endoscopic therapy. That can be therapeutic and potentially even more diagnostic, because sometimes these lesions are upstaged after we do get the specimen. For T1B lesions, this is the small category of patients where we would recommend upfront surgery. And that's because this cohort of patients tends to not benefit from neoadjuvant therapy. Oftentimes the morbidity of the neoadjuvant therapy outweighs the benefit of the neoadjuvant therapy in this small patient group. We may offer endoscopic options in these patients if they may not be a good surgical candidate or they have no high risk factors such as lymphovascular invasion or perineural invasion. The vast majority of patients, T2 to T4 or node-positive patients, will be offered some type of multimodal therapy. Oftentimes, it's our group's preference. If we have proximal GE junction cancers, that we go with neoadjuvant chemoradiation. I'll talk a little bit about those options on the next few slides. And that's also important to note that T4B disease, whether there's true metastatic disease or not, is oftentimes considered unresectable. This is where the tumor is locally advanced and is involving the heart, great vessels, trachea, other things that we cannot resect on our initial or primary resection. So oftentimes these patients are treated with definitive chemoradiation and are not offered surgery. So if we go back to our case, this is the same picture that was on the last slide, but we have a Siewert type 1 tumor that's 5 centimeters above the GE junction. The endoscopic ultrasound shows invasion into the adventitia, which is a T3 lesion with one hypoechoic lymph node. So we have a T3N1 lesion. This is a stage 3 patient. So typically what that means is we would offer that patient some type of neoadjuvant or perioperative therapy. So when we talk about GE junction cancers, we have a few options, and these are because many of the clinical trials that have looked into this in the past have included not only esophageal or gastric patients, but also a combination of GE junction patients within the trials. So any of these options are acceptable, though I will say that the NCCN prefers and our group prefers for esophageal and type 1 and 2 GE junction cancers to go with preoperative chemoradiation. I've listed a few of the trials here that I'm referring to. The CROSS trial by far is probably the most recognizable to many people in the room. It provides the basis for neoadjuvant chemoradiotherapy that we use in this patient population. As far as perioperative chemotherapy goes, you may be more familiar with these trials in the gastric cancer patient population, though both the MAGIC and FLOT4 trials did have GE junction cancer patients, so that is an acceptable way forward on these patients. And then finally, historically, the OEO2 trial from several years back looked at preoperative chemotherapy alone. All of these did show a benefit over upfront surgery, but our preference is for preoperative chemoradiation. So this is just a busy slide just outlining some of the details of the CROSS trial, which was published in 2012. It looked at patients with resectable esophageal cancer and randomized them into upfront surgery versus neoadjuvant chemoradiation followed by surgery. The chemoradiation regimen was carboplatin and paclitaxel, followed by 41 gray of concurrent RT. The unresectable rate improved from 13% to 4% in the neoadjuvant group. The R0 resection rate, which means there's no visible tumor pathologically on the specimen, at the margin improved from 69% to 92%. Even more impressively, the pass CR rate was 29%. This was much higher in patients with squamous cell carcinoma, but it's still impressive. Morbidity and mortality were the same, and the median overall survival was doubled in the patients that received the neoadjuvant chemoradiotherapy versus upfront surgery alone. So this was really practice-changing, and this really forms the basis of how we treat our patients that require neoadjuvant or multimodal therapy. A little bit more details on some of the other trials we talked about. So the MAGIC and FLOT4 trial were two different types of regimens, did demonstrate an overall benefit, overall survival benefit. There are GE junction patients included in all of these trials, but our preference, again, is to proceed with neoadjuvant chemoradiotherapy. Part of that is because of nodal distribution in patients with esophageal and GE junction cancers. We feel like the nodal metastases tend to localize more in the mediastinum, and in the mediastinum there's less collateral damage with the administration of neoadjuvant radiotherapy when compared to gastric cancer. So that's really the reason why we prefer that, plus I think the data is better. So back to the case. So once a patient has completed their neoadjuvant chemoradiation, we see them back and we do what's called restaging, and this is just to make sure they haven't developed any progressive or new metastatic disease while on neoadjuvant therapy. If they do, they would no longer be offered surgery, but in the vast majority of cases, we do get a really nice response. If that's the case, we do start talking to them about surgical resection. This is a very long discussion, requires a lot of education on the patient side. The operation itself is quite a large one, requires a lot of nutritional support and recovery. So we spend a lot of time with our patients just discussing what that looks like and what the expectations will be after surgery. The other thing that's really important for us, and anybody in the room that does this work, is making sure the patient selection is appropriate. We want to make sure the patients have an acceptable performance status just to go forward with the operation, because you can certainly make people worse by offering them this surgery if they're not good candidates. So what we've developed at our program, a lot of people around the country are doing this as well with great success, is prehabilitation. So all of our patients, after they're restaged, if they are deemed surgical candidates, we actually put them in a program that's led by one of our nurse practitioners, where they're enrolled in weekly physical therapy, nutritional support and education, as well as psychology visits to really prepare them in every way, shape, or form for the operation that's upcoming. And we've seen really good results anecdotally. We're about 15 months in. What is really nice to see, oftentimes we'll put patients that are maybe borderline candidates into this program, and we'll get them to a point where they're able to tolerate surgery and actually do well with surgery. So it's been nice to see that, and I think you'll see that coming online even outside of the foregut cancer world and other aspects of large complex surgical patients. So, okay, I'm moving into the technical part of the talk. I'm going to show a lot of pictures. I'm going to try to be as straightforward as possible, but I just wanted to share with everyone some of the technical aspects of these operations and what goes through our head when we're seeing these patients. So when we're talking about performing a GE junction resection or an esophagectomy, there's really several portions of the operation that are important. The first is being able to mobilize the esophagus and the stomach in order to perform the resection safely. The second is to perform an appropriate lymphadenectomy, which means removing all the lymph nodes that would be involved with the cancer or potentially have cancer within them. And they can be located in two different areas, right? This is the junction between two different places in the body. So we can look at the mediastinal lymph nodes, or those in the chest, and then those in the abdomen that are associated with the stomach. And then finally, what we need to do is create a way to reconstruct that patient once we've removed the esophagus. So we use the stomach preferentially as a conduit. So we make a tube out of the outside of the stomach, which is the longest portion, and we're able to bring that up to the neck to create a new connection between the top of the esophagus so that gastrointestinal continuity is reestablished at the end of the operation. So there's three main ways to perform an esophagectomy, and really the first one I want to highlight here is an approach called the transhiatal approach. This involves incisions in the abdomen and in the neck. So most of the time you'll start in the abdomen and perform all those steps I just outlined and create that gastric conduit, perform the lymphadenectomy and mobilize the esophagus, and then move to the neck to complete your resection and then perform your reanastomosis. What's nice about this approach, you'll see with the other two, is that it does not involve any incisions on the chest or any surgery within the chest cavity. So patients that have underlying pulmonary disease, previous surgery in the chest, or wouldn't tolerate single lung ventilation, which is what we have to do in surgery when we operate on these patients, this is a really good option for them. I think the downsides from a surgical perspective is the lymph node dissection in the chest is significantly reduced. If you're lucky if you really get any lymph nodes in the chest doing it this way. That's because a lot of the dissection in the chest is done bluntly with your fingers, like you can see in this picture here. The other two approaches involve surgery within the chest. The first one is the Ivor-Lewis approach, and this is an operation where typically is started in the abdomen, and all those steps I outlined again are accomplished. But finally, the patient is repositioned, and the patient, an incision is made on the chest, and the esophagus is mobilized within the mediastinum, and those lymph nodes can be harvested. They can be easily visualized and harvested, and then the new connection, instead of being made in the neck, is actually made in the chest. So that tubularized stomach is pulled up and reanastomosed within the chest. And that's that picture to the far left. The center picture is the McEwen esophagectomy. This is a 3-hole esophagectomy and is a combination of the last two approaches that I just outlined. This is our preference and our practice. We feel like we're able to accomplish all the goals of the operation, an acceptable or better than acceptable lymphadenectomy, and manage any potential complications best with this approach. And the way it works is we do everything we do the same way as I described in the Ivor Lewis esophagectomy, except at the end, we do bring everything up to the neck and do the connection in the neck. That's important because the most feared complication with this operation is a leak at the new connection site, and that can occur 15 to 20% of the time. And when leaks occur in the chest, they can be quite morbid and challenging for the patient to overcome. So we prefer them to occur in the neck where we can easily manage them and we feel like the patients do better. The big trade-off with any neck incision versus any other type of approach is that there's always a risk of injury to the recurrent laryngeal nerve, which is the nerve that controls your vocal cords on that side. So it is a small but real risk, and it's something that we're willing to accept based off of the morbidity of the potential leak in the chest. So in our group, we've really moved almost completely to doing these operations minimally invasive. I think if any operation lends itself to this, the esophagectomy does. And that's because a large thoracotomy or incision on the chest can be quite painful, affect patients' postoperative pain and recovery so much that it can really hinder their ability to get out of the ICU or even out of the hospital in a timely manner. So these are just examples of how we use the robot and where the incisions are for these, and we're able to do either of these three approaches robotically in our practice as long as the patient is an acceptable candidate. And I'd say about 80 to 90% of our patients are. So I want to show some videos here just to show you guys what this looks like. The robotic system itself has to be docked once the patient is already positioned. And I just want to take you through a few of these steps. So this is the thoracic portion of the dissection, and this is one of the sealing devices that we use to do the dissection. But you can see the esophagus being mobilized in the center of the picture, and we have a little Penrose drain around it. And this is how we mobilize the esophagus within the chest. And we're able to easily visualize all the lymph nodes that occur around the esophagus and around part of the airway so that we can make sure we do a good lymphadenectomy and harvest. So once we've completed the mobilization in the chest, we move to the abdomen. And this is a little bit of a longer video, and I'll talk through it a little bit. But in the abdomen, we're accomplishing the goals that we talked about earlier. We're mobilizing the bottom of the esophagus, which you see here. This is the true GE junction. We're separating it from the diaphragm, which is what's happening here. And the first step here is just to make sure we can get it free enough to make sure we get it resected. So once we've done that and freed it circumferentially, we move to the lymphadenectomy or the lymph node harvest in the abdomen. So most of the lymph nodes that occur in this disease process occur along what's called the left gastric pedicle, and this is an arterial supply to the stomach. And this is us skeletonizing the left gastric pedicle here, and all that fatty kind of nodular yellow tissue that's being delivered up is that lymphatic packet that goes along with those vessels. So what we're trying to accomplish here is really all of these lymph nodes will come up and be resected with the specimen all together. So you're not only resecting the primary tumor, but the associated lymph nodes with it. And then finally, once that's all complete, we move forward with making that conduit or tube of the stomach for reconstruction. And this is the stapling device you see right in the center of the screen. And what we're doing here is we're using the greater curve of the stomach, the outside of the stomach, and we're stapling it to make a perfect tube, and you can kind of visualize that here. And this tube will be used to be pulled up to the neck behind the heart within the chest and replace the esophagus once the esophagus has been resected. Everything to the left of the stapler is actually specimen. That's the lesser curve of the stomach, and the GE junction. That will come out with the esophagus, tumor intact with lymph nodes and everything that we talked about earlier. So this is really the process by which we make that tube to perform the reconstruction. And then finally, like I said, we do the three-field esophagectomy in our practice. We pull that tube up. This is a neck incision. It's just a single picture. But the structure to the right is actually that gastric tube we were formulating in the last video, pulled up to the neck incision. And then the clamp on the left, that's the bottom of the top, that's the transected esophagus, so the proximal esophagus. So what we're going to be doing here is making a connection between those two structures. And this is the completion of the case. This is what we do at the very end. And the way this is made is we use just a stapling device, just like you saw in the last video, to make a connection between those two structures. And then that formally reestablishes gastric continuity after the resection is completed. So just a few highlights, some of the surgical principles that we feel are important during these operations. Number one, the extent of the lymphadenectomy. I think our group feels that this is better with a thoracic dissection, so either Ivor Lewis or McEwen. We can visualize these nodes and dissect them free and have them go with the specimen. Unlike some other disease sites, we don't have good data saying we have to get a certain amount of lymph nodes for adequate staging, but we feel that more is better, not only for staging, but to improve prognosis and treatment. The other principle is the cervical versus thoracic anastomosis. That's that new connection. We feel that thoracic leaks can be quite morbid, so we prefer to do this in the neck, even though there is a risk of potentially injury to the recurrent laryngeal nerve. Conduit choice, so replacing the esophagus. We prefer to use the stomach. That's the number one choice for most people across the country. There are times when we cannot use the stomach to replace the esophagus. If the tumor is too progressive or involving too much of the stomach, or if the stomach doesn't have good blood supply, we can't use it. So there are other options. They're a little bit more complicated, but we can use colon or even part of the small intestine to do that replacement, to form that conduit. And then finally, post-operative nutritional support is really important in these patients. It's a long operation, challenge to overcome. Patients come in not optimized nutritionally typically, so we place jejunostomy tubes in all these patients in order to get them going as soon as possible on some type of meaningful nutrition in hopes that we can get them recovered quicker and back on their feet out of the hospital. All right, so the last thing I just wanted to touch on is adjuvant consideration. So prior to a few years ago, we did not have any good data for adjuvant therapy in patients that received neoadjuvant chemoradiation. Checkmate 577 was published, I think, about 2 years ago, and it looked at patients that had resectable esophageal cancer that received neoadjuvant chemoradiation and randomized them to adjuvant immunotherapy versus observation. The caveat was they had to have residual disease on their final pathology, so they couldn't be a complete response. And what they found was the disease-free survival was doubled in patients that received adjuvant immunotherapy. And the risk profile was perfectly acceptable. So this is now the standard of care in patients that do not achieve a path CR after their neoadjuvant therapy. And I think it's been really groundbreaking, and I think it's just the beginning of more and more to come for immunotherapy in the GI world, which I think has lagged behind some of the other disease sites. All right, so in conclusion, I think it's important that we have standardized classification and staging. This is imperative to guiding not just medical, but surgical management of these patients. As we talked about on several of the other slides, multimodal therapy is paramount in this patient population. We know it improves outcomes, improves overall survival in the GE junction patient population. There's several surgical approaches. This varies based off tumor location, nodal burden, and then surgeon preference and comfort. Some people are trained certain ways, and that's how they like to do it every time, and that's okay. Immunotherapy is the standard of care in adjuvant patients that don't obtain a path CR, and I think there'll be more to come on that in the coming years. And then finally, I think it's important to understand that you need more than just a good surgeon to accomplish the goal of appropriately taking care of these patients. We have a great team. Navigation, nutrition, medical oncology, radiation oncology, prehabilitation, survivorship, all these things are really important in order to successfully navigate these patients through this challenging treatment paradigm. So with that, thank you guys for having me, and I'm happy to take any questions.
A question about your prehab program. Average duration of rehabilitation, and do you have any difficulty in getting it covered or paid for if there is some challenges there?
So the duration, we usually do it 4 to 6 weeks, so it's that waiting period between end of neoadjuvant therapy to surgery. The caveat is if patients aren't progressing like we like to see, we will oftentimes move surgery back to accomplish the goals that we're trying to accomplish to get them there. As far as reimbursement, I actually don't know the answer to that. I'm not sure how that plays. I'm not really involved in that aspect of it. So I'm not really sure, to be honest with you.
I can answer to that.
Yes, Kim.
For the consult with the nurse practitioner, it's always paid for. Physical therapy is also paid for. The one that is more challenging is the counseling part that is more challenging. So I guess it depends on your insurance.
Like I said, the other two is always paid for, except the counseling part. So it's like a 50-50, depending, on what your documentation is about.
And the other big challenge I will just on the prehab that we do have is a lot of our patients do come from out of town. So that is a big challenge for us, and working with physical therapists, finding these resources for them closer to home, because to ask them to come to New Orleans several times a week for these can be quite a burden, as we've heard from several of the other talks. So I think that's a huge challenge for us, especially along the Gulf Coast. It's really tough. Any other questions? Yes.
Are you doing anything different for squamous cell?
No, so the approach is pretty similar. The only way that changes is if it's a proximal squamous cell carcinoma, oftentimes they'll be treated with definitive chemoradiation. And that's really just based off of tumor location and the ability for resection. Squamous cell carcinoma responds much better to radiation. The squamous cell cohort within the cross trial actually drove that path CR percentage, which is important to note. But really, in mid to lower esophageal squames, we are still offering them surgery and taking them down this similar pathway, unless they're not good candidates. But the proximal esophagus squames, we are typically treating with definitive chemoradiation, just because surgical resection and positive margins tend to be a little bit higher there.
Any other questions? All right. Thank you, Dr. Pointer. That was great.